Good morning. Good morning, distinguished guests, colleagues, and friends. It is my great pleasure to welcome you to this special day held here in historic Hofburg Palace in heart of Vienna. Today is the day number 3 of SNT, called Quantum Day. And this is not just another technical session, it's a quite historical moment and milestone for the SNT. For the first time in the history of conference, we are dedicating an entire thematic block to the topic of artificial intelligence. My name is Jaroslav Penda, and I have the privilege of moderating this morning session. AI is no longer distant innovation. AI is rapidly transforming how we work, how we collaborate, and how we run our research and study. From science to operation, to policy, development, and security. But with this opportunity comes responsibility. As we bring AI to our daily life, we must understand how it works. We have to know our algorithms. We have to know their capacities and their limits. And we have to ask the right questions. Is it safe? Is it secure? Is it compliant? Is the solution should be hosted on cloud or it should be always on premise? And we must ensure it's aligned with our ethical standards. Most important, because AI is always relies on the data, we need to make sure that data is accurate and unbiased. Only then we can build the trust and use AI responsibly. We will begin our morning session with keynote presentation by Professor Georg Langs from the hosting country, Austria, from Vienna Medical University, titled AI in Medicine, Data, Models, Trust, and Global Preparedness. Mr. Langs, welcome to SNT.
Thanks a lot for the very kind introduction, and thanks a lot for the invitation and the possibility to be here. It's really an honor to speak at that conference. My name is Georg Langs. I'm from Medical University Vienna, and I'd like to talk about how AI and how machine learning has changed healthcare, has changed how we deliver care, how we make decisions in medicine, but also how we develop new approaches in medicine. And if you would have asked me to give this talk 2 or 3 years ago, it would have been a very different talk. I would have talked about how research is exciting, how we will eventually reach applications, safety, that will allow us to deliver these algorithms in practice. But this time is over because now these algorithms are in practice. And here is an example out of Vienna that's from the neurosurgery theater where Georg Wiedholm is performing neurosurgery on a tumor patient. And he has been involved in the development. It is now using in daily practice a system that allows him to classify tissue samples that he's extracting during neurosurgery in order to very quickly say, is this normal tissue? Is this still tumor? What kind of tumor is that? And that allows him to do that a couple of times during the surgery. And that results in much more accurate delineation of the tumor, much better results from surgery. So that has reached practice. Another example coming out of our university, but having been spun off into a company and now being deployed across Europe in hospitals and being used to process more than 20,000 patients every month, are systems, or in this case a system that allows to identify disease patterns in chest CT data, allows them to classify them, and also allows us to detect lung nodules and to give a prediction, give a risk of whether this lung nodule might be malignant, might be developed into cancer, or might be just a benign nodule that just needs a follow-up examination. So these are examples that show that we have reached a stage where AI is happening in daily clinical routine. And in the next couple of minutes, I'd like to share a couple of lessons learned that we have learned on the way. And during the preparation of the keynote, we discussed about the topics that would be interesting. And so I thought I structured the talk around 3 topics: interpretability, trust, and safety. So when we step back and ask what role machine learning and artificial intelligence has in medicine, I think a very simple way to put this is it helps clinicians in what they do all day, and that is try to predict what will happen to a patient in the future. So all the data that we have about the patient, the imaging data, the laboratory data, the history, the comorbidities, take this information at a certain point and try to say what will happen to the patient. What will happen to the patient if we don't do anything? What will happen to the patient if we apply a certain therapy? And that has become more and more relevant as the landscape of therapies becomes more complex, and we need machine help in order to make the right decisions for individual patients. So one of the big application fields of AI is helping in the treatment decisions, helping in patient management decisions during routine healthcare. And there it's spreading, and there I'd like to show you a couple of examples. But the second purpose and the second role of machine learning that has come up in the last couple of years and has become stronger and stronger is to not only look at the point of care where we have a treatment option, where we have a patient, where we just want to decide what's the right treatment, but also looking into the future and trying to help us in developing new treatments. And there machine learning is now a big part of studies where we use it in order to be better at quantifying change, better at differentiating the response to treatment or the non-response to treatment, but more and more also machine learning helping us to understand biological mechanisms based on the data that we see. And that sounds a bit high level, so I'd like to give you a couple of examples that illustrate what that really means. So machine learning, deep learning, convolutional neural networks have helped us to be able now to look at imaging data and let algorithms segment and identify organs, anatomical structures, so we can let computers navigate in the body of patients, understand what is in front of the algorithm, and also tell something about whether something is out of the ordinary or whether it's normal. It has helped us to take different imaging modalities, in this case magnetic resonance imaging, PET imaging, diffusion-weighted imaging, CT imaging, to combine the characteristics across these images, which we are able to somehow do by just looking at the images, but now we are able to quantitatively say, well, can we use that? And we can use that in order to tell there is a tumor, there is not a tumor, what kind of tumor is there in the patient. And we see that that has quite clear advantages in terms of being sensitive, being early in detecting these tumors. And it also allows us to scale the detection of disease, to look at very large data sets, in this case full body MRI images that take a long time to investigate, where we are actually looking for a couple of spots that might be suspicious and might be a trace of cancer. And what you see on the top is 2 actual cancer lesions, and on the lower part you see the same body with the lesions or the lesion candidates marked by an algorithm that tells you, well, we can detect the lesions. We have a couple of false positives, which is a fact and which we have to manage. But you can imagine that that helps in detecting these lesions, because it allows us to concentrate on the really suspicious areas in the body, might shorten time, but right now primarily increases the sensitivity to detecting these lesions. And that helps in healthcare, right? That helps when we treat an individual patient, but it has also an effect on how we can learn from large-scale data, how we can kind of progress with inventing new technology, inventing new diagnostic procedures, in understanding the disease mechanisms. Because once we are able to automate, once we are able to algorithmically detect disease traces in data, we can observe that across large populations, and in this case start to observe what are the pathways, what is the distribution of these lesions, what are the typical spreading patterns in patients that help us in the next step to think a bit more about how can we improve diagnostics, how can we improve treatments of these patients. One thing that has happened very rapidly, and I think also that happens when new technology comes around, is that AI is now used in almost all of the scanners that we use. So we use computer tomography scanners, magnetic resonance imaging scanners, and we use AI, machine learning, deep learning algorithms to perform the reconstruction from the raw data to the actual data to the 3D data. And here's an example out of my lab, together with the MR Center, where we use machine learning in order to reconstruct spectroscopy data out of MR data. And the effect of learning, of using deep learning for this, is that we can reduce the scan time because we can reconstruct these images from less sensor data. So we are able to compensate for lack of sensor data and still create high quality images. And that in practice reduces scan time, which has a lot of effect on the processes in the healthcare system. But in this case, it moved spectroscopy from a modality that is interesting for research but not feasible in clinical practice to a time window that is feasible in clinical practice. And we'll touch later on what that means, because of course you can imagine if I trust deep learning to reconstruct the imaging data that I use for diagnosis, being able to trust that it doesn't miss anything, that it doesn't make anything vanish, is one of the more important questions. So let's have a look at how that affects healthcare, what we think in healthcare about when we are thinking about should we adopt AI or not. And let's tackle these three questions, right? Interpretability, trust, and security. So the three kind of draws from healthcare why people want to use machine learning is, first of all, we are thinking about efficiency. Can we be better and faster at performing diagnosis? We think about the quality, and I think that's one of the most important parts. Can we perform better diagnosis compared to what we could do without AI? And the last point is we are starting to think on a healthcare system level of what is the impact of AI on a healthcare system level. What is the impact of AI changing decisions, making decisions possible at an earlier time point? What does that change in the flows of patient populations? What does that change in the overall pathway of a single patient when they go through treatment, recovery, and surveillance after the treatment? And for all of those, data quality, interpretability, and trust are important points. So let's have a look at each of them individually. So deep learning has been long in this, let's say, cliche of being very hard to interpret, but I think like we are now beyond that. So we see that we can start to interpret what AI models are doing to an extent that is necessary in order to check them, in order to understand the certainty that is coming with AI assessments of patient data. But what we have also learned is that AI is actually a very useful tool in helping us to interpret data. So I think AI is a tool that helps us to understand what we see in front of us better, to extract relationships, to extract patterns that we did not see without AI. So let me show you a couple of examples. So this is a patient suffering from an interstitial lung disease, observed over 1.5 years. And what you see on the bottom are patterns in this imaging data, that's computer tomography data, that were identified by algorithms. And we didn't tell the algorithm anything, we just told it, or programmed it to find patterns that occur across many patients and then track them over time. And you see that many of these patterns stay stable because it's healthy lung tissue, it's vessels, it's airways. But some of these patterns on the right upper part of the lung, they change over time, right? And this gives us a sensory tool that allows us to model progression of disease, to model what are the commonalities within a certain disease group and what helps us to differentiate between different diseases. And in this case of interstitial lung diseases, it helped us to move the point at which we can perform a reliable diagnosis between two different disease types to an earlier point, because we can now quantify and grasp the dynamics that are playing out during this disease with a vocabulary that allows us to quantify and to compare patients. And again, that helps us to say something about the future of the patient, so if this is a high-risk patient or a low-risk patient. And here we come to the point of trust that we have now, as a fairly standard procedure, once we develop an algorithm, we validate it, but we almost always have to develop it on a second cohort. So in this case, it was developed in Italy or in an Italian cohort, and we verified it in an Austrian cohort. So international collaborations are key to get reliable algorithms and to get data exchange and governance going that enables the development and validation of reliable algorithms for healthcare. But again, we can also look back and say, well, does that also tell us something about the disease? Does that let us interpret the data? Does that discover us pathways of how this very healthy lung tissue becomes diseased lung tissue over time. And here's another example out of lung imaging. So these are emergency patients who got a CT within the first hour of arriving at the hospital. Every column, one patient, and the features are telling us how these patterns are distributed in the data. And we don't have to go into detail, but when you kind of close your eyes a little bit, you will see that there are a couple of groups of patients, right? There are areas in this plot that show us, well, there might be a couple of different categories of the patients. And the interesting thing is that these categories of patients that share what's going on in their lung do also share what's happening to them in the next 2 or 3 years, 2 or 3 days while they are in the hospital. And in this specific cohort, it's really important to understand if there is a risk of something that is called acute respiratory distress syndrome, because if you know about this risk, you can improve a lot about the outcome of these patients. And this group that is marked with the red circle at the bottom, this is the group of patients that do have, that actually had ARDS during their stay in the hospital within the next 2 or 3 days. And what you see on the top is that these patients seem to have a very peculiar, very particular profile in what we see in the imaging data. And that is about interpretability of the algorithm. So we can go back and see where are these patterns, where are the changes in the lung that are associated with high risk, where are the traces, the signatures that turn this patient into a high-risk patient. But I think going back to the utility in the clinic, what we see here is an ROC curve. The main important thing is that the farther up to the left upper corner you are, the better your differentiation between low-risk and high-risk patients. What we learned is with these scores, relying on imaging data and machine learning, we can outperform all of the established clinical scores that predict this risk, right? So I think AI is not really only a tool for automating what we can do right now, but it's also a tool in kind of expanding what we can say about patients, what we can tell about their future. And here a quick third example about explainability, about interpretability, where we, in this case in breast cancer patients, there is a big question and a lot of research around understanding the molecular subtypes of breast cancer. And with machine learning, we can trace the molecular subtypes to specific areas in the tumors and tell more about the heterogeneity of these tumors, the different traits that are occurring in different parts of the tumor. And that again enables us to not only speak a single tumor, a single subtype, but speak more about the heterogeneity of this data. So I think AI can be interpretable, but I think it's also a tool for interpreting data. Second, security, managing risk and quality of algorithms. You can imagine that in healthcare, risk is a very important point, right? We think about risk all the time. We know that none of our tests, none of our procedures are 100% accurate, and AI is adding to that. And so we found, or we learned, that we can't wait for 100% accuracy, but we have to instead invest into procedures that help us to detect risk, assess risk, quantify probabilities, and then start mitigation strategies. And one example here out of lung cancer screening. So this is a CT of a lung cancer, or of a screening patient or a clinical patient, and the task here is to detect nodules. We found that AI is a big help in detecting them, but we have to weigh the sensitivity of these methods in deciding how many false positives, how many nodules detected do we want to accept in terms of additional work in evaluating them versus how many false negatives we want to prohibit. And one way to think about that, and I think that is when we are now turning from looking just at the images, just at the algorithms, looking at how AI impacts the pathway of the patient. So a patient that does a CT, we get the AI algorithm running, we get the evaluation of the patient, and this patient would go a certain pathway in the clinic, right? The patient would go either home, or the patient would go home and we would call them back in a year for a scan, or we would immediately escalate from CT to PET-CT, or we would perform a biopsy. And the question is, what does AI change about that? How many of these patients change their pathway? How many of the biopsy patients do we reroute to just do an additional scan? How many of the patients who we send home we reroute to biopsy and maybe save them a year in having earlier treatment start for their cancer? And the way to think about that is, I think, to think in what we know from guidelines, what we know from assessing risk and probabilities, These are patients out of the National Lung Cancer Screening Trial in the US. The color tells you something about the risk profile without AI. There are some of the low-risk patients who still develop cancer, and AI can help us to reclassify some of them as high risk. There are some high-risk patients who actually don't get cancer, thankfully, but the AI allows us to reclassify, to downgrade some of them of being low risk and to spare them the biopsy. And that has an impact on the healthcare system, but that has also a lot of impact on the individual. So I think when we think about risk and safety, we have to think about the entire pathway, the entire consequence of the use of AI, and assess how this is changed by AI. And I think the last and maybe most important point is trust, right? Think about the governance of data, think about the governance of algorithms, the availability and the sharing of algorithms, and I think that is something where international organizations play a big role. And I'd like to show you, as a closing of the talk, the example of the Zodiac Observatory that we are very honored to be involved in, led by the IEEA as part of the Zodiac project. And the idea or the goal of the Zodiac Observatory is to have an early warning system for pandemic diseases and to have an infrastructure that allows data sharing and rapid response during the initial phase of the disease. So let me show you what we looked at before we designed this observatory together with the team at the IAEA. So we looked at 4 prior pandemics, at the timelines from the detection to the first treatment, to the first diagnosis, to the first kind of effective plan of managing these diseases in the larger populations. And we saw very similar a couple of patterns. So first pattern was that imaging data was always involved in the first description of the disease, in the first recognition and characterization of the disease, clinical imaging, because these patients were in the clinic. But we also saw that for all of these representative data to train algorithms was not available or available too late, or when it was available, it was really poor quality, it was biased, it was a mess of confounding factors that intermingled with the actual disease factors that made it very hard to train algorithms. So we had heterogeneous data, and that resulted in heterogeneous validation and in a very long runtime. So it took a year to have a good algorithm to detect COVID effectively in data. And the last thing is there was no mechanism to deliver algorithms, right? So algorithms were developed and they were used where they were developed, but there was no mechanism of saying, well, let's use the scientific community to develop a good algorithm. A lot of the scientific community was involved, but once the algorithm was there, it was hard to deliver it to clinics. And the Zodiac Observatory aims at helping, right, improving that. It aims at being quick at detecting a new disease, being quick at getting strategies going in order to counter it, in order to manage it. So we view it as a long timeline of seasons of different diseases that are present in the population. At some point, a new disease pops up, and the first goal of Zodiac Observatory is to have sensory stations across the world, globally, in different hospitals to detect this onset very quickly and determine that there is a new emerging disease that we have not seen before based on the phenotypes that we see in the clinic. The second goal is once we see the disease, once we know that it's there, to very rapidly collect data, curate data, and provide it to the scientific community in order to create good algorithms that predict the course of a patient. And that's important in order to manage patients, right? In order to send them home or get them to intensive care, but also to decide for specific treatments. Here are a couple of early results of this project. So this is a result where we see that we are starting to be able to detect new diseases, right? It's a difficult problem to detect something that we have never seen before, where we have no training data. We can only say there is something new, there is the probability arising that what we are seeing right now in patients, we have never seen before in patients. And never seen before in patients is a difficult task because the patient population, the imaging technology, it's so heterogeneous that we have to develop algorithms, and we are developing algorithms that is still able to differentiate what are heterogeneous imaging technology traces and what are actually traces of a newly emerging disease. And I think the role of big international organizations in terms of trust, in this case the IAEA, is that we are able to convince clinics around the world, countries around the world to share data, to join forces, and in this case the structure is there is a shared computing and storage facility that draws data from clinics around the world, has them in a safe, governed place that is governed by the organization, and allows AI algorithms to be trained on this data. Let me again remind you of the two aims. So we want algorithms that detect newly emerging diseases early, right? That detect, well, there is an uptick in something that we have not seen before, and also algorithms that allow us to predict what will happen to patients even if we haven't seen a lot of patients like that before. And I think a repository, an observatory governed by an international organization that allows the collection of data from many sites, but it also allows the development and application of algorithms from the entire research community is the way to go in order to kind of get the best minds to focus on solving these problems. And so we are right now in this development phase, and with that I'd like to thank you for your attention, and I'm happy to take questions. Thank you. We can.
Check, check. Thank you. Jörg, thank you for excellent presentation.
Thanks.
From the audience, do we have questions? We have time maybe for one, maximum 2 questions. I see hand. Yes, please.
Yeah, hi, I'm Birger Steen from Northstar in Norway. The pandemic had these points where people came up with really good ideas. One was Open Safely in the UK, where all of a sudden everybody could interrogate the entire set of primary health journals, electronic patient journals. And I think you spoke about the importance of having representative and unbiased and normalized, hopefully, data that you could let loose on. Number one, how important of a barrier is that in your field right now? And what are the next sort of hurdles you need to cross to get past those?
Yeah. So thanks. That's a very important question. So it's true that there was data available, and we were also part, and I think many were part of big initiatives because there was a lot of energy in sharing data. The barrier was to get enough information about the data to understand whether, just a very simple example, you have data where you have patients with COVID and patients without COVID. But when you look deeper into the data, then you recognize that all of the patients with COVID were 50-plus-year-old persons, and all the patients without COVID were from a different geographic regions, and they were all below 30 years old. That's a very plastic example, but a lot of algorithms were trained on this data where they were really detectors of age and not so much of the disease. And so I think like one of the barriers was getting enough information about the patients, getting the information that allows you to build a data set that really is controlled for a lot of factors and allows you to train an algorithm that actually detects the disease. So I think the barriers are, and they still are there, in sharing comprehensive clinical data in an anonymized way in a system that allows jointly working on that data.
Thank you, Gert. Any other question? Yes, please.
Hi, thank you for the amazing talk. Based on your presentation and from research from all the colleagues, it seems that the solutions are here today now. I'm pretty sure that you have heard about the EU AI Act and other rules for compliance, for the development of pipelines, and avoid bias and risk. So what can you tell us that you can foresee in perhaps 2 to 5 years projection into the field of medicine regarding to this governance? Because we know that it's good for predicting patterns, but it cannot think, it cannot reason. So what is so more of a precise question would be, in this projection of time, what are we doing today that can predict the risk or potential biases of tomorrow?
So, I think that in order to get data where we understand the biases, where we understand how well algorithms will apply and run on patient populations that are very diverse, I think one big strategic move, and I think there are things happening in the European Union, in the US, and across the world, is to create data repositories that are representative of large data populations, right? We have to be honest, if I'm in a big academic center, I see only very special types of patients that go to a tertiary care center. But what we need in order to have algorithms that really serve a wider population is to have the data of this wider population. That's one thing, and I think that's obvious, but I think the even equally important point is to also integrate these different geographic regions in the research, right? I think it's not the right strategy to have the research centralized and pool data from everywhere, but I think it's the right strategy to also involve those places, those institutions from which the data is coming into the research, because that kind of, I think, ensures you that these are also populations that are well served, and it also ensures that you don't overlook real problems that have to be solved when you're applying AI. I hope that was a good answer.
Thank you, Georg. I have another question which was coming online, and this was about the specific role of international organizations in enabling of affecting use of AI. So you were working already in the past, as you mentioned in the Zodiac project, with international organizations. What do you see? What is the role of the organization?
Yeah, I think the role of international organizations is based on the trust that is put in them, right? So I think it's easier to trust international organizations with performing the governance of large sensitive data, of controlling and organizing and coordinating the sharing of this data, but also in making sure that the developments that are coming out of the AI that is developed on this data are actually then distributed and disseminated in a way so that everybody profits from them. So I think the role of AI, of organizations like IAEA and other international organizations, are that they have trust by the community, they have trust by countries, by institutions, and I think the value of the trust is that enables them to, together with these partners, perform the governance of the data, enable this sharing, but also enabling kind of the provision of the results to everybody.
Thank you.
Thanks.
Okay, so let us wrap up with this part, with the keynote presentation. Thank you, Georg, again. Close. And now we will start our panel discussion with our panelists, and also Georg will be part of the panel. So if you still have questions, you can ask them during our discussion. And let's invite our panelists to the floor. Thank you.